Just to start off, this is our inaugural or very first OBGYN Global Health Case Competition. It's a collaboration between Penn Medicine, OBGYN department, and the Center of Global Health. Before we start, I just want to thank the judges for being here, all the presenters and people who submitted all the interesting cases. It was very great to read through those and the attendees who are here today. And a special thank you to Darren, Charlotte, and Alejo for helping bring this competition together. The purpose of this is to highlight clinical challenges shaped by local context, and it's also designed to amplify trainee voices in global women's health. And before we get started, the traditional framework of how global health typically works is that knowledge flows, for years, is knowledge flows from a high resource settings and to the low resource settings, where we export these guidelines and protocols and try to reshape them to fit the context in where resources are limited. And innovation is assumed that it can only occur in one setting and be brought to another setting. However, there's a growing call for us to reconsider how we have approached global health in what is more of a bidirectional learning process. So allowing knowledge and innovation to flow both ways and learning from local experts about the constraints and how to adapt to them. And in addition, instead of looking at resource limitation as a deficit, looking at it as something that can help create new innovations and how to approach caring for our patients when we don't have all the available resources that some of these higher income regions have. And so for this specific case competition, there were 20 selected cases from a global pool of applicants. Each case has roughly 5 minutes of pre-recorded presentations that they submitted, and the judges will score the cases after each block. And then at the very end, audience participation with the People's Choice voting. So as you're watching, just take some notes about what you thought was interesting and which case presentations you particularly enjoyed. So for this specific case competition, we have a great representation with finalists from Nigeria, Vietnam, Ghana, Tanzania, Pakistan, and Kenya. There were over 60 submissions received with 20 cases selected for the presentation. And for us judges, we'll be judging primarily on clinical reasoning and diagnostic approach, understanding of the clinical and health system context, the appropriateness of the management decision, and then a learning and teaching value and overall clarity in organization. And so for the People's Choice Awards, these are the things that we ask you to keep in mind when you are judging as well. And as mentioned on the call for abstract, this will be the awards and recognitions, and this will be announced at the end of the competition. All right, great. So while we do this, I ask everyone to remain muted. We'll be asking questions in the chat. So if it's your presentation at the time, feel free to respond to the questions in the chat, and then we will deliberate for a bit before announcing the winners. Okay, excellent. If you have any questions before we start, feel free to put those in the chat. Otherwise, I will have Darren take over as we start to put the presentations on the screen.
Everyone, thank you very much for joining. Before we start with the first video, I'm just going to go quickly through how we've organized the presentations. Actually, we'll just be going in alphabetic order by family name. So you can see, maybe you can see where you fall in this. And each presentation is 5 minutes. So you may be able to calculate when you will be
this is the order that we'll be going in. We'll present first 10 cases, we'll take a short break, and then complete the remaining presentations afterwards.
Okay. Sorry, one moment, my computer's having an issue.
We're just trying to figure, we're about to display the first presentation. We're just figuring out some of the technical difficulties.
Everyone, I'm Dr. Anga Fatima Inusa.
All right, we're going to start with the first presentation. If there's any difficulty hearing this, please let me know.
Hello, good day, everyone. I'm Dr. Anga Fatima Inusa from the Department of Obstetrics and Gynecology, Federal Medical Center, Abuja. And I'll be making a presentation on the fallopian tube schistosomiasis, presenting as ruptured ampullary ectopic pregnancy. My mentor is Associate Professor Ibrahim Rabiu, and team members include Dr. Muhammad Rahman Lawal, Dr. Usman Abba, Dr. Muazu Ishaq Shuaibu, Associate Professor Ibrahim Rabiu, and Professor Lawan Aliyu Ibrahim. I have no financial or non-financial conflicts of interest to disclose. And by way of introduction, I'd like to emphasize that female genital schistosomiasis is a neglected tropical disease and also a disease of public health importance that burdens the developing and underdeveloped nations. It is underreported and is also an underreported manifestation of schistosoma hematobium. It involves the upper genital tract, and then involvement can actually lead to chronic inflammation, causing fibrosis, calcification, and even tubal distortion. And it can be associated with infertility, recurrent pregnancy loss, and ectopic pregnancy, as will be seen in the case that I have to present. The case is that of a 25-year-old multiparous woman. She's gravid 6 para 0. 5 consecutive first trimester pregnancy losses. And when she presented at the gynecological emergency, I would say she had acute severe abdominal pain and vaginal bleeding. And there was a positive history of rural residents with frequent freshwater exposure. There was no pelvic surgery, no STIs, no assisted reproductive technology, as well as any underlying medical condition. On examination, she was pale, she had tachycardia, and she had hypotension. Abdominal tenderness was present with GYN, and there was cervical motion tenderness and right adnexal mass. An urgent pelvic ultrasound scan done revealed a 7 weeks gestation with features of ectopic pregnancy, specifically in the right tube. Immediately, the patient was walked up for an emergency exploratory laparotomy, and she gave consent for which she had. We found significant hemoperitoneum. There was right ruptured ampullary ectopic pregnancy, and subsequently, a total right salpingectomy was done for her. Subsequently, we took samples of the fallopian tube, and we took it for histopathology. And the findings were that of the granulomatous inflammation of the fallopian tube, calcified schistosoma hematobium ova was identified, and the diagnosis was that of fallopian tube schistosomiasis. This picture actually depicts the histological section of the fallopian tube of this individual. And as you can see, this is the schistosoma hematobium egg. Her management was uncomplicated. Post-operative recovery was good. We administered praziquantel, and then we give adequate reproductive counseling and fertility follow-up. Currently, as I speak with you, she's still on follow-up in the hospital. Key points to note in this case is that FGS is likely underdiagnosed. It is also a significant cause of upper genital tract infection, as well as ectopic pregnancy and infertility, as seen in this case. It is also important to note that high index of suspicion is very important, especially in women who live in endemic areas. And routine histopathology also enables diagnosis and secondary prevention. By way of conclusion, I'd like to say fallopian tube schistosomiasis is an overlooked but preventable cause of ectopic pregnancy. And there are urgent interventions that are required in this area. This includes strengthened surveillance, integration of FGS screening into reproductive health services, increased clinician awareness, and research. With this, I'd like to conclude and say thank you for listening. My reference is Wright et al., 1982, the WHO International Journal for Parasitology. Thank you.
Thank you. Wow, that was very interesting. As someone who lives abroad, I've never, female genital schistosoma is not something we often see. So thank you for bringing that to our attention. We're going to move on to case number 2. All right, we'll be starting case number 2.
Good day. I'm Dr. Michael Azikian of the Department of Obstetrics and Gynecology, University of Benin Teaching Hospital, Benin City, Nigeria. I'm presenting shared genes, shared disease, genetically linked endometriosis with mirror clinical presentation and treatment outcome. This is my mentor, and these are my team members, who are all from the University of Benin Teaching Hospital. At this point, I would like to declare that I have no financial support to declare, and there's no conflict of interest to this presentation. Endometriosis is a chronic gynecological condition defined as the presence of functional endometrial glands and stroma outside of the uterine cavity. Now, despite the unclear etiology surrounding endometriosis, several theories have been proposed, and one of them is genetic predisposition to endometriosis, which is typified in this case with where we have extrapelvic presentation in identical twin sisters. Extrapelvic presentation is quite uncommon, and even more common is umbilical endometriosis. Now, that's in all makes this case very, very special. 30-year-old identical twin sisters walked into the gynecological clinic complaining of cyclic pelvic pain, dysmenorrhea, and menorrhagia. Pain was severe enough to impair daily activities. They also complained of cyclical umbilical pain, swelling, hyperpigmentation, and occasional bleeding from the umbilical during menstruation in both sisters. These sisters attained menarche at 13, and they noted dysmenorrhea at 16. This image is the image of twin-one's umbilicals before surgery. They also developed umbilical symptoms at 26. Meaning, just a few months apart of each other, they also developed ovarian endometriomas at different times, still within a short interval between each other. Twin-1 had a laparoscopic ovarian cystectomy, and twin-2 had ultrasound-guided ovarian cyst aspiration. This surgical approach caused transient symptomatic relief, and even at presentation of physical examination, nodules were palpated at the level of the umbilical in both twins. Now, these sisters were placed on prolonged gonadotropin-releasing hormone agonist therapy, for which they experienced transient symptom relief, excluding the umbilical symptoms. Subsequently had the excision of umbilical nodules and umbilical reconstruction. The excised nodule was sent to the pathologist for histology, and the finding of endometriosis was confirmed. The sisters were placed on gonadotropin-releasing hormone agonist continued after surgery, and for which they experienced total resolution of symptoms. And they are on it today, they are very happy and they are very comfortable. This is an image of reconstructed umbilicals post-op. Now for the teaching points. This case supports the genetic theory of endometriosis as demonstrated by the rare occurrence of extrapelvic endometriosis, particularly umbilical endometriosis in identical twin sisters. It also highlights the need for a high index of suspicion in the face of for extrapelvic endometriosis when patients present with cyclical pain or bleeding from unusual sites. This case emphasizes the importance of detailed and focused history taking, especially when similar symptoms occur in the same family. Our experience also demonstrates the limitation of conservative surgical approaches alone, such as cystectomy or cyst aspiration, in achieving sustained symptom control. Medical management, the gonadotropin-releasing hormone agonist therapy was effective in controlling most symptoms. Counseling, as well as peer support, played a huge role in encouraging adherence to prolonged therapy. Remember, there were sisters that were going to the clinic together and receiving this care together. Finally, this case underscores the importance of multidisciplinary care and person-centered care. Collaboration with the plastic surgery team was phenomenal in managing these umbilical lesions, pigmentation, achieving acceptable cosmetic and outcomes, and supporting the patient's psychological well-being. Also, it's very important to note as a take-home that this case highlights the value of multimodal treatment, highlights the use of gonadotropin-releasing agonists and surgical excision of residual nodule, umbilical, and also umbilical reconstruction as effective management strategy in controlling symptoms long-term and ensuring physical and mental well-being, respectively. Multimodal treatment, multidisciplinary care, person-centered care, and peer support is justified and advocated as a means of ensuring good reproductive health. Thank you very much. These are my references. Thank you very much.
Good morning. My name is Guyen Yi, presenting on behalf of Win University.
Which I still can't fix the issue.
Good morning. My name is Guyen Yi, presenting on behalf of Win University.
So that previous case, very interesting, and also highlights how much we still have to learn about endometriosis. So thank you so much for sharing. We will move on to our third case, being presented on homozygous alpha thalassemia.
University, Vietnam. This case illustrates. Good morning. My name is Guyen Yi, presenting on behalf of Win University, Vietnam. This case illustrates how delayed screening in a high prevalence setting can lead to severe fetal and maternal consequences, and how to prevent such adverse outcome through screening, diagnosis, and early intervention in countries like Vietnam. Before going into the case, I have no conflicts of interest to disclose, and this case is presented with ethical and educational integrity. To provide some background, alpha thalassemia is one of the most common inherited hemoglobin disorder worldwide, and in Vietnam, approximately 1 in 7 individuals is a carrier, making this a major public health concern in our countries. In its most severe form, homozygous alpha-thalassemia is usually fatal without treatment and is associated with serious maternal and fetal complications, as you can see on the screen. So this patient was a 30-year-old preemie gravida with no known medical comorbidities who presented for routine antenatal care. At her 12 weeks of gestation, the screening showed a low risk NIPT and a normal.
Sorry, Bridget. Your screen's not sharing. Do you mind restarting the presentation?
Oh, my apologies. I will reshare right now. Is everyone able to see the screen now?
No, not yet.
How about, all right. My apologies for that. I didn't realize. Is everyone able to see it now?
Yes.
Perfect, great.
Good morning. My name is Yi, presenting on behalf of University Vietnam. This case illustrates how delayed screening in a high prevalence setting can lead to severe fetal and maternal consequences, and how to prevent such adverse outcome through screening, diagnosis, and early intervention in countries like Vietnam. Before going into the case, I have no conflicts of interest to disclose, and this case is presented with ethical and educational integrity. To provide some background, alpha thalassemia is one of the most common inherited hemoglobin disorder worldwide, and in Vietnam, approximately 1 in 7 individuals is a carrier, making this a major public health concern in our countries. In its most severe form, homozygous alpha-0-thalassemia is usually fatal without treatment and is associated with serious maternal and fetal complications, as you can see on the screen. So this patient was a 30-year-old preemie gravida with no known medical comorbidities who presented for routine antenatal care. At her 12 weeks of gestation, the screening showed a low-risk NIPT and a normal nuchal translucency of 1.0 millimeter. However, the hemoglobin nopathy screening was not performed at that time, and these details become particularly important later as the patient lived in a region with high thalassemia prevalence. The pregnancy progressed uneventfully until 28 weeks of gestation when targeted ultrasound was performed. At that time, the Doppler assessment demonstrated the middle cerebral artery peak systolic velocity of 1.6 mom in terms of interpretation. A value greater than or equal to 1.55 mom missed the diagnostic threshold for severe fetal anemia. And in addition to the Doppler findings, a detailed structural ultrasound provided further evidence of disease severity. On subjective assessment, the fetal liver appeared enlarged on the transverse abdominal view, occupying nearly the entire abdominal cavity. And on the right picture, you can see that the heart of the fetus was also severely enlarged, occupying almost the entire thoracic cavity. And in addition, the placenta was markedly thickened, measuring 6.04 centimeters, indicating placental megaly. And taking these all together, it represents advanced disease with evolving hydrophytalis and significant hemodynamic compromise. So based on the findings that we have, we did the CBC and molecular testing. The results of both parents showed microcytosis and hyperchromia with the confirmation of homozygous alpha-thalassemia due to Southeast Asia deletion. Unfortunately, at that time, due to the late gestational age at diagnosis and the presence of hydrophytalis, management options were very limited. While hematopoietic stem cell transplantation is the only curative treatment, it remains largely inaccessible in Vietnam due to many reasons, such as high cost, limited donor availability, technical complexity, and significant risk. So after multidisciplinary counseling, the parents elected to proceed with the pregnancy termination. So this case represents a missed opportunity for early screening. This led to an important discussion point. What could have been done differently? So in Vietnam, current guidelines recommend initial screening using the single CBC index, particularly MCV and MCH. When the index are low, further evaluation with hemoglobin electrophoresis and genetic sequencing can identify carrier couples early. Ideally, intervention should occur before marriage and before pregnancy. And when both parents are identified as carrier using PGTM before implantation or CVS from week 11 to week 14, we will have further intervention. So from this case, several key teaching points emerge. The first one is alpha-thalassemia major is common, lethal, but preventable. The second is normal first trimester and aploidy screening does not exclude hemoglobinopathies. Third, simple CBC index alone with MCV or MCH can identify most high-risk couples early. And last but not least, Early detection enables appropriate counseling and future reproductive planning. So ideally, screening should occur before marriage, before conception, or early in pregnancy. And that is the end of the presentation. Thank you for paying attention.
Wow, that was very, very interesting. So we've now seen presentations on fallopian tubes, schistosoma, endometriosis with mirroring within twins, and then alpha thal carrier and how that affects pregnancy. We're just gonna, as the judges, we're just going to take a second to look through these three cases that we've seen. If anyone has questions, feel free to put them in the chat, and those who are here from the first three cases can answer them while we are reviewing. All right, great. We'll proceed with case number 4.
I'm Dr. Emmanuel Vigwatu from the Department of Obstetrics and Gynecology here at Nnamdi Azikiwe University Teaching Hospital, Nnewi, under the mentorship of Professor Uchenna George Eleje, the professor at this institution. I'm here to discuss urethral carbuncle in pregnancy as a rare but important meaning of antepartum hemorrhage. And I have no conflict of interest here. Here in sub-Saharan Africa, where I practice, hemorrhage in pregnancy is still a very common cause of significant fetal-maternal morbidity and mortality. An obstetrician who is faced with bleeding in pregnancy, this in itself is a race against time, where the expectation is that he or she would marry medical knowledge with the requisite speed and accuracy of diagnosis and intervention to optimize fetal-maternal outcomes. And it is against this backdrop that we managed this 21-year-old private gravida at a gestational age of 31 weeks plus 3 days, who presented with a 7-day history of painless vaginal bleeding that was intermittently profuse, often coming in clots. She had no prior history of abdominal pain or trauma, no history of dysuria, abnormal vaginal discharge, For reduced fetal movement, there was no history of cough, hemoptysis, or bleeding disorder. Vital signs on physical examination were normal. Her abdomen was non-tender, and her uterine size was appropriate for a gestational age of 31 weeks. On pelvic examination, the vulva was blood smeared. On patting the labia, we found a solitary fleshy non-tender mass that measured about 1 by 1 centimeter and was located at the posterior margin of the external urethral meatus. Also had bleeding on contact. Our speculum examination revealed a cervical pus that was closed and had no evidence of bleeding. Her baseline investigation, including a packed cell volume done, was within normal limits, and her serum beta HCG to rule out gestational trophoblastic disease was normal for her gestational age at a value of 4,060 international units per liter. The obstetric ultrasound sound done revealed a viable intrauterine singleton gestation at a gestational age of 32 weeks in cephalic presentation, normal amniotic fluid volume, and with an anterior placenta that had no evidence of placenta previa or abruptio placenta. The image shows the woman we found on that day, the gravid abdomen and urethral caruncle in situ. The urethral caruncle was located at the posterior margin as shown. And then, following our exclusion of the common cause of antepartum hemorrhage, we made a diagnosis alongside our pelvic examination finding. A diagnosis of urethral caruncle in pregnancy was made. Our patient was then cancelled and she chose the conservative mode of care, following which we admitted her and started her on topical estradiol plus 1% hydrocortisone, which she applied 12 hourly over a period of 4 weeks and continued her routine prenatal supplements. By the second day on admission, her bleeding had stopped, and by the third day following evaluation, we discharged her. Her follow-up visits continued 2 weekly over a period of 6 weeks, and by the last visit she had prior to delivery, the caruncle had disappeared. She subsequently had vaginal delivery, which was uncomplicated, at the gestational age of 39 weeks to a live male baby with a score of 8 in 1, 10 in 5, and a birth weight of 3.0 kg. And from this case, we learned and wish to share that urethral caruncle in pregnancy can occur in pregnancy, and that in itself, it is a rare cause of antepartum hemorrhage, as the only reported case in pregnancy was that of Park in 2004, and ours may be the second case reported in pregnancy. It is in itself a diagnosis of exclusion, and as such, a clinician, having ruled out the common cause of antepartum hemorrhage, should think of urethral caruncle. This diagnosis, however, requires that the clinician do a thorough pelvic examination, pat the vulva, inspect it properly, pat the labia, inspect the vulva properly, which may possibly reveal the urethral caruncle. And following our findings, we hereby wish to recommend that in subsequent literature that on antepartum hemorrhage, the urethral caruncle be mentioned as a known cause of antepartum hemorrhage, as this will help early diagnosis, proper treatment to forestall complications. Thank you for listening. These are my references. Thank you.
Thank you for this clear and thoughtful presentation. When we are evaluating for antepartum hemorrhage, I think we'll often think of cervical and placental causes. And so this is something to keep in the back of our minds when we are evaluating and the typical diagnosis, and it's not presenting as the typical diagnosis. So we'll just take a few seconds to deliberate on this one, and then we'll come back to present the next one.
Good morning.
Good day, everyone.
Okay, we'll be presenting the next case on abnormal antenatal cardiotocograph and umbilical artery Doppler findings due to cord hypercoagulability.
My name is Dr. Anat Isaraji, a senior registrar in the Department of Obstetrics, Gynecology, and Perinatology at the Obafemi Awolowo University Teaching Hospitals Complex, Ile-Ife, Osun State, Nigeria. My mentor is Dr. Ibrahim Awowole, and I'll be presenting a case report titled Abnormal Antenatal Cardiotocograph and Umbilical Artery Doppler Findings Due to Cord Hypercoagulability. I have no conflict of interest to declare. Stillbirth is an obstetric catastrophe, and every measure needed to reduce its occurrence would greatly impact families. While some causes of stillbirth are apparent, others are less apparent and requires appropriate skills and high index of suspicion in order to identify them. Despite being closely linked to adverse perinatal outcome, umbilical cord abnormalities remain significantly underdiagnosed in the perinatal period, more so in resource-limited settings such as ours. Hypercoiling of the umbilical cord is one of the identified umbilical cord abnormalities, defined as an elevated umbilical coiling index greater than the 90th centile in the antenatal period, or the presence of more than 3 coils per 10 centimeter segment of the cord. This case highlights the diagnostic and clinical implications of a hypercoiled umbilical cord presenting with reduced perception of fetal movement and abnormal fetal surveillance. The patient was a 34-year-old Guarita 3 para 2 alive who presented at an estimated gestational age of 33 weeks with complaints of reduced perception of fetal movement of 2 days duration. There was no labor pain, drainage of lichen or bleeding per vagina. She had no similar history in previous pregnancies and no medical conditions of note. Physical examination findings were within normal limits, and obstetric examination confirmed a well-grown singleton fetus in cephalic presentation with a fetal heart rate of 142 beats per minute. The ultrasound scan done showed an appropriately grown live fetus with normal liquor volume. The umbilical cord was coiled into a loop with afferent and efferent arms. The pulsatility index in both arms were at 50th centile. However, there was absent diastolic flow in the umbilical artery at different points within the loop. Cardiotography done showed deep deceleration with concerning characteristics, and an assessment of true cord knot was made to rule out umbilical cord hypercoagulability. She was counseled on the findings and the need for immediate delivery via cesarean section and was delivered of a live male baby who weighed 1.8 kilograms with APGAR scales of 8 at 1 and 10 at 5. The umbilical cord was markedly hypercoiled with about 7 coils per 10 centimeter segments with areas of hypercongestion and edema. The baby was admitted into the neonatal ward on account of prematurity and had a good outcome following prompt intervention. This was the intraoperative image of the hypercoiled umbilical cord with at least 7 coils in this segment and an edematous upper segment with areas of hypercongestion and edema. This case brings to fore an uncommon variant of umbilical cord accident that could have led to a perinatal mortality if not promptly recognized and managed. Vasilios et al. In their meta-analysis on umbilical cord coiling index for a prediction of adverse pregnancy outcome identified that there was a significant association between hypercoagulability and adverse outcomes like prematurity and increased need for interventional deliveries, as was the case in my patient. They also noted that this could range up until the end of the spectrum of fetal demise. Carmente et al. Also in their study on postnatal umbilical coiling index and its association with perinatal outcome in a tertiary care facility in India noted significant association between hypercoagulability and cesarean section, as in this case, and also with gestational diabetes, which was not the case in my patient. As teaching points, hypercoagulability can interfere with fetal placental circulation and its known sequelae. About 50% of women who had stillbirth reported reduced perception of fetal movement, and this explains the deliberate effort that was put in place to identify the cause in this patient and treat it promptly. The abnormalities on the Doppler findings and the cardiotocograph served as objective adjuncts in risk stratification. The pattern of umbilical coiling, which is often overlooked, may actually provide important insights into fetal well-being. To conclude, umbilical cord hypercoilability should be considered as a differential diagnosis of reduced perception of fetal movement and unexplained abnormal fetal monitoring. This case illustrates the pivotal role of integrating maternal symptoms with Doppler ultrasound and cardiotocography in providing timely obstetric intervention. These are the references. Thank you.
Thank you for that presentation on decreased fetal movement and umbilical cord hypercoagulability. It is adding to our differential and how to best manage those patients who come in presenting with decreased fetal movement and cardiotocography abnormalities. So again, we'll be taking a few seconds to score, and then we'll move on to the next case. All right, we'll be presenting the next case on sigmoid volvus entrapped by a pedunculated fibroid in mid-pregnancy.
Good morning. My name is Samad Naikai. I'm a resident doctor in the Department of Obstetrics and Gynecology at the University of Benin Teaching Hospital, Nigeria. Today I'll be presenting a case titled sigmoid volvulus around a pedunculated fibroid in mid-pregnancy when common diagnosis misleads. This case highlights how frequently encountered condition in pregnancy can obscure evolving surgical emergency, particularly in low-resource setting. I have no conflict of interest to disclose. Informed consent was obtained and the patient confidentiality has been strictly maintained. This was a case of a 28-year-old unbooked primary gravida at 23 weeks gestation with uterine fibroid diagnosed before pregnancy. She presented to the University of Benin Teaching Hospital, a tertiary center located in low-resource setting where access to advanced imaging is limited, especially during pregnancy. She presented with 1 week history of progressive worsening abdominal pain, initially epigastric and intermittent, but later migrated to the left flank and eventually became generalized. This was associated with fever, anorexia, and bilious vomiting. Importantly, there were no diarrhea, no urinary symptoms, no vaginal bleeding, and no prior abdominal surgery. The absence of early constipation contributed to delayed suspicion of bowel pathology in this patient. On examination, she was febrile, pale, dehydrated, etheric, tachycardic, and had borderline hypotension. Initial diagnosis revealed malaria parasitemia, a packed cell volume of 31%, and a sterile urine culture. Ultrasound scan that was done confirmed a viable intrauterine pregnancy and a fundal uterine fibroid with cystic degeneration. At this stage, malaria in pregnancy and red degeneration of uterine fibroid appear to sufficiently explain her presentation, particularly as she resided in malaria endemic zone, where these symptoms of fever and abdominal pain strongly biases early diagnostic reasoning. Despite the anti-malaria therapy which she was on and the resolution of fever, her abdominal pain worsened atypically. Bilious vomiting persisted and she developed complete obstipation beyond 72 hours. The apparent reduction in pain, which was noted at about the third day on admission, occurring alongside a silent abdomen and an increasing distension, marked a critical turning point in this case. This raised concern for bowel ischemia rather than clinical improvement. Given the discordant clinical causes, reassessment was undertaken. As she was at 23 weeks gestational age, imaging was deliberately limited with pelvic shielding applied to minimize fetal radiation exposure. Radiography nonetheless demonstrated features consistent with mechanical bowel obstruction, prompting urgent surgical consultation. She had an emergency laparotomy done, which revealed a 270-degree anticlockwise sigmoid volvulus, with the sigmoid column twisted around a pedunculated fundal uterine fibroid, which acted as a mechanical lead point. Addicolysis and detorsion were performed, followed by myomectomy, as the fibroid had minimal intramural extension. The gravid uterus was preserved and fetal viability was maintained throughout the procedure. Post-operative recovery was uneventful. She registered for antenatal care. The pregnancy progressed to term, and she achieved a spontaneous vaginal delivery of a healthy neonate with no maternal or fetal complications. This case highlights some key lessons. First, acute abdomen in pregnancy is dynamic, and persistence of or progression of symptoms mandates repeated reassessment beyond initial diagnosis. Secondly, anchoring bias towards common conditions such as malaria or fibroid degeneration may delay recognition of life-threatening surgical emergencies, particularly in low-resource settings. Finally, timely imaging and multidisciplinary surgical intervention can allow excellent maternal and fetal outcome, even following mid-trimester laparotomy. Thank you.
Thank you for sharing that case on some differentials or something to think about when a patient who's pregnant presents with an acute abdomen, especially in the presence of fibroids. As you've highlighted in the case, timely management is very important. Very glad for a good outcome. So we'll be moving, shortly, we'll be moving on to the next case in a bit, but we'll be taking some time to deliberate. Okay, we'll be presenting the next case, which is on a novel approach in dengue fever complicated by sickle cell in pregnancy.
Hello, everyone. I am Ruben Iweka, a fourth-year resident in the Department of Obstetrics and Gynecology, University of Benin Teaching Hospital, Nigeria. I'll be presenting this case report titled From Certain Mortality to Survival, a novel approach in dengue fever complicated by sickle cell in pregnancy,
My mentor is my head of department, Professor Ian Nabudoso. Other team members are Dr. Bayabo and Dr. Benson Okwara. So we'll be presenting using this outline. We do not have any conflict of interest to declare, and consent was obtained from this patient for this presentation. So dengue fever is a viral hemorrhagic disease which can complicate pregnancy. It can lead to complications in both the hematological system and other systems in the body, as well as end organ damage. It can also lead to fetal death and maternal death as well. Sickle cell disease on its own can also cause complications in the hematological system as well as end organ damage. So when these two complications or conditions are added together, it is near death for the woman, especially in low resource setting. So we had 3 patients prior to this case who had active dengue fever in pregnancy and died following delivery. So we decided to manage this patient differently. Currently, there is no consensus about the timing of delivery for dengue fever in pregnancy, and there is limited guidance for low resource setting on how we should manage this patient despite the high burden of this condition. So we had a 32-year-old on Bugravier 2 para 1 at a 7-week gestation, a non-sickle cell patient with 1 previous cesarean section who presented with 5-day history of high-grade fever with chills, progressive jaundice, severe bone pains, as well as body pains. She was febrile, she was pale, deeply etheric, in painful distress, but her pulse and blood pressure were normal. There was no active bleeding from craniofacial orifices or any part of her body. The fetal cardiotocography was reassuring. This gave us opportunity for non-emergency decision making. At presentation, she had severe anemia of 16%, severe thrombocytopenia, 40,000. The liver function and the electrolyte urea and creatinine were deranged. The dengue fever polymerase chain reaction test was positive. On the day 11th, she was delivered following viral clearance. She had hyperhemolytic crisis on the day 12th, and she was stabilized and discharged on day 19. So, due to our experience of 100% mortality, we decided to employ a delayed delivery approach, prioritizing viral clearance. She was co-managed with the hematologist, the nephrologist, and infectious disease team, and we monitored the fetal heart closely. She also had intravenous fluids. On the 11th day, we had viral clearance, and we noticed that she developed spontaneous labor. Following that, we noticed that she also had fetal distress. On suspicion of uterine scar dehiscence, we did an emergency cesarean section for her with outcome of a live female neonate. The finding confirmed the uterine scar dehiscence, as you can see here on the slide. Following delivery, she developed hyperhemolytic crisis, as we can see here on the slide, with tea-colored urine. She was managed in the high dependency care unit with steroid treatment, street fluid input-output balance with anticoagulation treatment. Hypokalemia was corrected and further transfusion was withheld with back-cell volume of 25% due to the active hemolysis. Both mother and baby were managed and discharged in stable condition after 19 days of mother's admission. The follow-up has been unremarkable. From our findings, only study by Reddy et al. Showed a patient with dengue fever and sickle cell pregnancy, but interestingly, this patient had delivery following a presentation with labor pain. And also, this patient did not have complications like us. So we recommend from our finding that it is better we achieve viral clearance and maternal stabilization before delivery, as this will prevent complications. Also, hyperhemolytic crisis should be anticipated and proactively managed. There is need for multidisciplinary approach. Our case provides a replicable framework for viral hemorrhagic disease in pregnancy, and sometimes the safest delivery is the one you deliberately delay. These are my references, and thank you for listening.
Ladies and gentlemen, welcome to the clinical.
Thank you for that interesting case that highlighted the need to manage communicable diseases in pregnancy and the impact that it can have on the patients that we care for. So we'll just again take a second to put in and then we will start with the next case. All right, for our next case, we'll be presenting on the presentation will be on advanced BRCA1 mutated ovarian carcinosarcoma in an elderly patient.
Welcome to the clinical navigation of advanced BRCA1 mutated ovarian carcinosarcoma in elderly patient. Diagnostic challenges, treatment complexity, and a role PARP inhibitor. My name is Nam from Vietnam. There is no conflict or disclosure to declare. Now, I would like to begin. The 74-year-old female with history of well-controlled diabetes, hypertension, presents with a chronic abdominal pain. 2 months prior, she developed a constipation and unintentional weight loss, 7 kg over 2 months. 1 month prior, she had a persistent lower abdominal pain from the right iliac fossa radiate to the left side, worse in the morning and before defecation. 7 days prior, the pain worsened, prompting hospital presentation. On admission, she had abdominal pain, VAS 6 out of 10, inability to pass stool, fatigue and poor appetite without GI bleeding and vomiting. Family history highlight the esophageal cancer, breast cancer, and hematologic malignancy. On physical examination, she was fatigued, otherwise normal, diffuse abdominal tenderness with multiple palpable masses, abdominal fullness, and aside was critically foul, atrophic uterus with tenderness and adnexal masses. Given her age, weight loss, and progressive bowel symptoms, colorectal cancer was suitable in the nice galley, but ovarian cancer was clinically considered. Here, we will do the test for both diagnoses. However, the FIT is unavailable in Vietnam, so we will do the remaining tests. Imaging revealed the right ovarian mass, about 6 cm with aside and peritoneal involvement along with a segmental pulmonary embolisms. CA125 around 1,400, HE4 more than 5,000, supporting ovarian malignancy. However, the CEA and the CA72-4 was elevated, raising the concern for gastrointestinal involvement or metastasis disease. Final pathology revealed the ovarian carcinosarcoma, figure stage 4, molecular profiling showed PD-L1 30%, low tumor mutational burden, predicting the limited benefit from immune checkpoint inhibitor. So now, should we go with the palliative care or do more tests? Surprisingly, the positive BRCA1 mutation definitely become turning point in management. Based on this, the team decided neoadjuvant platinum-based chemotherapy. There are some positive outcomes and anticipate complications. In neoadjuvant phase, there are some objective and functional response at the first chemo cycle, which is resolution of pulmonary embolisms. After the second cycle, the treatment was complicated by 2 episodes of recurrent C. diff infections over 20 days, treated with vancomycin and ciprofloxacin. 7 days later, she developed a malignant large bowel obstruction due to the peritoneal metastasis invading the sigmoid colon, requiring urgent diverting colostomy. After the third cycle, the marked improvement in symptoms and tumor marker is shown. She then underwent the interval debulking surgery with optimal cytoreductions. Post-operatively, she developed the surgical site infections with the extensive drug-resistant Enterococcus faecium, successfully treated with the linezolid, the only sensitive antibiotic. During adjuvant chemotherapy, she experienced a recurrent asymptomatic leukopenia, resulting in multiple treatment delays. Given the platinum sensitivity and BRCA1 mutation, she transitioned to the olaparib maintenance therapy in April 2025. After 8 months on olaparib, imaging showed a complete radiologic response with no residual disease and the CA125 suppressed to 6. In conclusion, 8 key points including advanced cancer frequently mimic each other, so never single track the cancer. Guidelines don't make the diagnosis, clinic do. Compared with the surgery alone, neoadjuvant therapy reduces systemic risk up to 40% without surgical outcome. Don't just react, but anticipate the complication. In high AMR setting, infections can be the dominant threat on oncology care, especially in Asia-Pacific region, with high recurrence and severity of C. diff and Enterobacteriaceae species. Modern oncology is vulnerability-driven, not histology alone-driven. BRCA tests, first introduced in early 2000, remain limited in many LMIC. In Vietnam, routine use began only in 2022, driven by the target therapy availability. Last, PALP inhibition maintenance in the SOLO-1 trial tells 70% reduction in risk of disease progression or death, fundamentally altering survival expectation beyond 5 years. This is the end of my presentation. Thank you for listening.
Thank you for this interesting case on BRCA1 mutations and how it changes our management. And as we know, as we are adopting more of this testing globally, we'll continue to learn how to best manage these patients going forward. The next case presentation will be on advanced abdominal pregnancy with intestinal obstruction. So take it away.
Hello everyone, I'm Lusajo Magobera, a resident in the Department of Obstetrics and Gynecology at Aga Khan University, Dar es Salaam, Tanzania. I'll be sharing a case of advanced abdominal pregnancy with intestinal obstruction case report. My mentors are Dr. Lynn Moshi and Prof. Musdalifat Abed. I have no financial or non-financial conflict of interest to disclose. This is a case of 17-year-old female, grade 2 para 1, with no living children. At 37 weeks of gestation age, where she was referred after unsuccessful intracervical catheter induction due to fetal demise. So she presented with a gradual onset of intermittent high-grade fever, sudden cessation of fetal movement 3 days prior to admission, and complaints of failure to pass stool or flatters along with abdominal pain. Antenatally, she initiated care at 14 weeks of gestation age and made a total of 3 uneventful visits, with exception in all visits, no ultrasound was ever done. Obstetric history included previous cesarean section 2 years ago, with unfortunately a baby passing away because of pneumonia. On examination, she was alert, dehydrated, febrile with temperature of 38.5. Vitally, she was non-intensive. On abdominal examination, it was asymmetrically distended, moving with the respiration. Tenderness was found on palpation, and the fetus was observed in transverse-like position with no detectable fetal heartbeats. The cervix was found to be posteriorly positioned, tip of finger dilatation, thick, and there was no any signs of effacement. An impression of intestinal obstruction and fetal demise was made. Laboratory findings include complete blood count showed mild leukocytosis of 12, hemoglobin of 10.6, normal platelet count, electrolyte levels were within normal range, malaria rapid test was done and it was negative, renal function tests were normal. Imaging, ultrasound was done and showed empty uterus with normal endometrial spread. Supine abdominal X-ray, because of intestinal obstruction, was done, which showed dilated bowel lobes, a transverse-lying fetus, and no engaged head in the pelvis. So, preoperative optimization with nasogastric tube, 4D compression, intravenous hydration, and prophylactic antibiotics were given. An emergency laparotomy was done, which revealed a macerated 3 kg fetus without an amniotic sac. And the fetus was delivered, umbilical cord was clamped and ligated. So the placenta, which was located at the anterolateral aspect of the uterus, was intentionally left in situ to prevent catastrophic hemorrhage, and the abdomen was closed in. Postoperatively, she received a single unit of packed red blood cells and a single dose of methotrexate to facilitate placenta degeneration. She had an eventful recovery, bowel function returned, and fever resolved within 24 hours. Before discharge on the third day, the wound was assessed and found clean and dry, so she was discharged and followed up 2 weeks later, where she had any complaint and was faring well. These are intraoperative findings, where the fetus was found floating in the abdomen, and as you can appreciate, a part of large bowel. And this was placenta that was located on the anterolateral aspect of the uterus, which was left in situ. Several takeaways from this case. First, abdominal pregnancy is a rare type of ectopic pregnancy, accounting for 1% with life-threatening potential to both mother and fetus. Especially in low resource setting, abdominal pregnancies are often detected at a later stage due to suboptimal antenatal care, such as in this case, lack of ultrasound assessment in all visits. So it's important to determine the location of pregnancy, viability, and placenta site to ensure optimal antenatal care. Induction of labor should follow after full assessment, which includes ultrasound. And in an abdominal pregnancy, placenta can be left in situ if removal is unsafe in order to avoid catastrophic hemorrhage. Thank you very much, and these are my references.
Thank you for this case, as it highlights the importance of keeping an abdominal pregnancy as a differential when addressing acute abdomen in pregnancy. Thank you for that. So we'll take a second and then move on to our next case. The next case will be presenting on intestinal obstruction secondary to necrotic subserosal uterine fibroids.
Good day, everyone. I am Dr. Gildas Mawara, obstetrician gynecologist and senior resident in the Upper West Regional Hospital, WA, Ghana. My presentation will be on intestinal obstruction secondary to necrotic subserosal uterine fibroids, a rare surgical emergency in a young woman. The authors have no financial relationships or conflicts of interest to disclose. Informed consent was obtained from the patient for publication of this case report and accompanying images. So she was a 30-year-old female who presented from a peripheral facility in the Upper West region of Ghana. She had a 2-day history of severe abdominal pain, progressive abdominal distension, and shortness of breath. She also had vomiting, constipation, urinary frequency, and urgency, but fever, diarrhea, and vaginal bleeding were absent. On arrival, she was generally stable, except for significant tachycardia of 125 beats per minute. The abdominal examination showed a visibly distended abdomen with a palpable, firm, irregular mass that measured about 20 centimeters by 20 centimeters. There were significant signs of peritonism, with generalized abdominal tenderness, guarding, and rigidity. There were, however, absent bowel sounds. An initial diagnosis of intestinal obstruction secondary to uterine fibroids was made. These were the accompanying laboratory tests and imaging. The full blood count, the hemoglobin level was 14.2, and there was an increased white blood cell count with neutrophilia. The platelets, renal function test, and liver function tests were grossly normal. An ultrasound showed subserosal uterine myoma measuring 16 by 17 centimeters. Addition to do a laparotomy with myomectomy was made. And intra-op, there were 3 subserosal uterine fibroids, with the largest necrotic as shown in the image, measuring 24 centimeters by 16 centimeters and weighed 2.6 kilograms. There were dense adhesions between fibroids and dilated loops of bowel, and approximately 2 liters of frank pus in the abdominal cavity. So a diagnosis of small bowel obstruction secondary to necrotic subserosal uterine fibroids was confirmed. This image shows the bowel, the uterus, and the huge subserosal fibroid, which was undergoing degeneration and was necrotic. So immediate post-op management, we put a strict nail per os. She had a nasogastric tube inserted for decompression. We put on maintenance IV fluids and potassium replacement. We put on antibiotics, IV clindamycin and gentamicin, and she was on thromboprophylaxis. The outcome, the recovery was unremarkable. There were no early complications, and she was discharged within a week. Outpatient follow-up was satisfactory. So, as we are all aware, uterine fibroids affects a huge chunk of women of reproductive age. Intestinal obstruction, however, is extremely rare, and you need to have a high index of suspicion if a woman of reproductive age presents with an abdominal mass with bowel symptoms. Subserosal uterine fibroids can cause mechanical obstruction via mass effects on bowel loops and dense adhesions formation secondary to degeneration. Prompt surgical intervention prevents life-threatening complications. Thank you. These are my references.
Thank you for that very interesting case. We are at the midpoint of the competition, and I just want to pause to say how impressed we've been so far. We've heard 10 really thoughtful and interesting cases highlighting management of obstetrics, gynecologic, and oncology cases across a range of clinical settings. We're now going to take a 10-minute break, and we'll resume shortly for the second half. Thank you to the presenters so far. So at around 10:33 or 10 minutes from now, depending on what your time zone is, we'll be back. Thank you. Welcome back, everyone, and thank you for being prompt. Um, just reviewing some of these, it's so interesting to see how things are managed differently and all across the world, as well as some of the endemic or infectious diseases that doctors or OBGYNs encounter in different parts of the world. And so we will go ahead and resume with the second half of the competition. And again, we're already so impressed with what we've seen so far. As a reminder, each case will follow the same format as before, and we're looking forward to the next set of presentations. Feel free to use the chat box if you have any questions. So we'll be setting up the next case.
Good morning, everyone. I'm Tu Nguyen, and on behalf of my co-authors, Chi Nguyen and Mon Chun, I'm honored to present a case titled Persistent Bleeding After Presumed Miscarriage, Diagnostic Challenges in Gestational Trophoblastic Neoplasia. This case highlights how a subtle clinical presentation can delay the recognition of a malignant condition and emphasize the need for systematic reassessment in patients with persistent bleeding after pregnancy loss. This case was prepared for educational purposes with informed consent obtained and no conflicts of interest declared. Our case is a 31-year-old female with no significant past medical history, gravida 2, para 2, who presented with abnormal uterine bleeding. 2 months prior to admission, the patient developed light vaginal bleeding of approximately 1 to 2 pads per day, consisting dark blood without clots, and was not associated with any other symptoms. After 1 week of bleeding, she sought care at a local hospital. With a positive beta HCG and no intrauterine gestational sac on transvaginal ultrasound, she was diagnosed as spontaneous miscarriage, and no follow-up plans or treatment was advised. The patient would continue to have vaginal bleeding over the following weeks. Because the symptom was mild, not interfering with daily activities, and no instruction was given previously, escalation of care was delayed. After 2 months of persistent bleeding, and given that she was actively planning to conceive, the patient decided to sought for further medical evaluation. On physical examination, the patient was hemodynamically stable. General examination was unremarkable. Abdominal examination revealed only mild pressure on deep palpation without any localized tenderness. Pelvic examination demonstrated a normal sized uterus, no adnexal mass, scant dark brown blood in the vaginal vault, and normal appearing cervix. Given persistent abnormal uterine bleeding, a prior positive beta HCG, and absence of intrauterine gestational sac, the differential at this stage remained broad, including both pregnancy and non-pregnancy related causes, prompting further laboratory and imaging evaluation. Laboratory results reveal beta HCG of over 6,000. Transvaginal ultrasound demonstrate a 28 by 32 millimeter left adnexal mass concerning for ectopic pregnancy, and the patient was scheduled for a diagnostic laparoscopy on the following day. The patient was discharged in stable condition while awaiting histopathology. Postoperatively, the beta HCG was reassessed and showed a significant declining trend, reaching below 5 after 3 weeks of operation. On laparoscopy, we identified a localized left tubal ectopic pregnancy without evidence of rupture, and laparoscopic left salpingectomy was performed. Histopathology later confirmed choroidal carcinoma of tubal origin. The patient was referred for oncologic evaluation and staging, and with no evidence of metastatic disease, the patient was classified as low-risk gestational trophoblastic neoplasia. Given her reproductive age and desire for future conception, a fertility-preserving approach was selected. She was treated with single-agent methotrexate 8-day regimen and scheduled for regular outpatient follow-up. At the most recent follow-up, which is 3 weeks after completion of chemotherapy, her beta HCG was below 5, and transvaginal ultrasound showed no residual or recurrent disease. From this case, we would like to emphasize several key points. First, persistent vaginal bleeding after a presumed pregnancy loss should never be considered benign and requires structural reassessment, including repeat beta HCG and imaging to confirm complete pregnancy resolution. Second, although gestational trophoblastic disease is more prevalent in Southeast Asia, tubal choroidal carcinoma remains extremely rare worldwide, with estimated incidence of 1.5 per million births, and may present with only modest elevations of beta-HCG, making early diagnosis challenging. Third, effective patient education regarding warning signs and return evaluation after pregnancy loss is essential to prevent diagnostic delay. Finally, early diagnosis allows for fertility-preserving management and leads to excellent reproductive outcomes, even in malignant conditions such as choriocarcinoma. And this is our reference for this presentation. And on behalf of my co-authors, thank you for listening.
Good morning, everyone. My name
Thank you for that thoughtful presentation on gestational trophoblastic disease in pregnancy. I will again take a second just to deliberate and come back to the next case. All right, presentation for the next case is on the contralateral paradox, a rare crossed OHBIRA variant with pilosalpinx of the non-obstructed side.
is Nguyen Phương Giang. I'm a six-year medical. Good morning, everyone. My name is Nguyen Phương Giang. I'm a six-year medical student from University Hanoi, Vietnam. I am pleased to be here today to present our interesting case that we observed during our clinical rotations. So this is our disclosure. Our case began with the 25-year-old newly gravid woman who presented with the severe dysmenorrhea lasting for 7 days. Her pelvic pain was progressive, cyclical with MENS with a VAS score of 7 out of 10. And she also reported episodic fever with a maximum temperature of 38.6 degrees Celsius, but no nausea, vomiting. Regarding menstrual history, her menarche started at 40 years old, regular cycle lasting for 7 days, and dysmenorrhea since her first menarche with recent worsening. Her last menstrual period was 1 week prior to admission, and there was no significant past medical history relevant to infection or endometriosis. Upon physical examination, she was stable, her abdomen was soft and non-tender. A pelvic exam, external genitalia was normal, and there was a small amount of dark blood in vagina, and there was only one cervix was identified. By manual examination, shown a right uterus distended with retained blood, and the left uterus in normal size. But also we found that there's a 2 centimeter tender mass on the left side. For the lab results, it suggests for inflammation signs, which is increasing of inflammatory marker such as white blood cell, CRP, procalcitonin, but other tests, including renal function and urinalysis, were unremarkable. For pelvic MRI shown uterus didelphys with 2 distinct cervices, the right uterus was distended consistent with hematometra, but for the anexa, the right ovary had a simple unilocular cyst, and the left ovary had a 40 by 50 millimeter ovarian endometrial cyst as ORA2. But the transvaginal ultrasound and confirmed the complex of left anexa cystic mass without Doppler vascularity. And beside that, the abdominal ultrasound showed the left kidney was not visually consistent with renal agenesis. Based on this information, we conclude two diagnoses. First, for endometriosis, supported by ovarian endometriosis, explaining her long-standing dysmenorrhea and likely contribute to adhesion. But secondly, for Hurlin-Werner-Gudelich syndrome, known as Ovira syndrome, based on uterus diaphysis with two cervix and the right hematometra from outflow obstruction and the left renal agenesis. That is a rare contralateral variant of Ovira syndrome. So based on the pre-operative assessment, the initial plan was laparoscopic exploration followed by right hysterectomy and vaginal fenestration. However, intraoperative findings were unexpected. The right anexa corresponding to the obstructed side appeared normal. However, the left side showed the severe pathology with a 3 by 4 centimeter biosapping filled with purulent material and dense adhesion to the posterior uterine surface. We also found the left ovarian endometriosis. Faced with severe inflammation and distorted anatomy, the surgical team abandoned the planned hysterectomy, and instead of that, they prioritized the source control, performing with left sapingectomy, left ovarian endometriosis cystectomy, and also adhesionolysis. For the definitive correction of Mullerian anomaly, would refer until the infection resolution. So this is clinically significant for four key point reasons. Firstly, it documents an extremely rare Ovira variant where the renal agenesis and genital obstruction occur contralateral side. It challenged the classical teaching. For the secondly, it revealed pathologic paradox. Which is the most severe inflammatory damage is pyosapping that occur on the non-obstructed side. Additionally, the ovarian endometrioma support a core ovivira mechanism that is unilateral outflow obstruction caused menstrual blood retention and retrograde menstruation predisposing to endometriosis and dense pelvic adhesion. Finally, it is a powerful lesson for surgical safety. That is the prioritization of life-saving infection control over the anatomy correction. So this case highlights the need for diagnostic flexibility, embryologic understanding, and surgical judgment when managing a rare Mullerian case. So that is our presentation. Thank you for your attendance.
Thank you for that presentation on a unique presentation of Ovira and also the intraop findings that were unexpected and how to shift and make sure that we keep patient safety a priority. So we'll be taking a break and then coming back for the next case. The next presentation is on pregnancy transaminitis, the gray zone of clinical laboratory mismatch.
Good morning, everyone. My name is Nguyễn Hoàng Sơn, and I'm from Vietnam. Today, I will be presenting a case of pregnancy transaminitis, the gray zone of clinical laboratory mismatch from a hospital. So let me start with a case. This is a 32-year-old pregnant woman, primigravida, a remarkable past medical history, 36-week gestation, went for prenatal checkup, but also complained symptoms of mild fatigue, myalgia, and dark color urine. However, the patient denied symptoms of fever, mucocutaneous lesion, abdominal pain, rash, or abnormal bowel habits. On the checkup, the patient, they were significant for elevated liver enzyme, approximately 100 and 300, elevated ALP, and increase in direct bilirubin. However, 5 days later, we got the result from the lab with the herpes simplex virus IgM positive. The other lab was unremarkable. Then, the patients were admitted to the infectious department immediately for safety concern. On the physical examination, the patient presented with stable vital sign, no edema, no rash, lesion, or jaundice. The other organ also revealed unremarkable sign. Obstetric exam also did a review on normal pregnancy with uterine height suitable for 36 weeks and fetal heart rate within normal range. As we discussed before, initial lab tests reveal elevated ALT, ALB, and bilirubin. The complete blood count and coagulation panel were unremarkable. In a patient presented with transaminitis, especially in a case of third trimester pregnancy, we want to discuss broad diagnosis to find the true cause. We are approaching the cause of infections like the TORCH group, usually seen in pregnancy patient. However, there were also life-threatening conditions we should be thinking of, like preeclampsia, eclampsia, HAP syndrome. Autoimmune disorder were also possible, like autoimmune hepatitis, BBC, BSC, or SLE. Other benign causes such as intrahepatic cholestatic of pregnancy should also be thinking of. We did a wide range of infectious cause and trying to explain like, can anything be explained for elevated liver enzyme except from the HSV, because HSV hepatitis usually presented with fever and very severe systemic symptom, which is unseen in this patient. Actually, we did a lot of like hepatitis A, B, C, E, CMV, ABV, HIV, leptospira. However, the results were all unremarkable except for HSV IgM positive. And of course, autoimmune cause should be discussed in a case of unexplained transaminitis, ANA, anti-DSNA, anti-LKMK1, anti-AMA, ceruloplasmin was done and came back, but also came back with the normal result. So far at this time, we got a range of options for diagnosis, but were all unreasonable except for HSV hepatitis. So our diagnosis at this time is still HSV hepatitis within a case of pregnancy 36 weeks. And for the course of treatment, we decided to give her IV prophylactic acyclovir immediately because we believe that we should not be waiting for a confirmatory test like PCR or an invasive tool like liver biopsy. Delayed treatment could lead to fatality. So we did also observe a decrease in liver enzyme after using the acyclovir for 5 days from approximately 100 over 300 to about 50 over 70. Moreover, clinical presentation also improved with no more fatigue. Later, patient deliver with neonate and discharged to the home safely. So here are my teaching points for the case. First, elevated liver enzyme during pregnancy could be caused by a variety of causes. Second, always maintain a high level of suspicion for pregnancy presenting with moderate fatigue, myalgia, unexplained transaminated, and with seropositive HSV. HSV hepatitis, though uncommon, is a high fatality diagnosis and delayed antiviral therapy is associated with poor outcomes in pregnancy. For acyclovir has been shown to be safe and well tolerated in pregnancy, and there is no reason to delay the treatment. And final is an hours of prevention is what a power curve by Benjamin Franklin. Um, so thank you for your listening.
Thank you for that interesting review on transaminitis and pregnancy and specific focus on HSV hepatitis. Our next case will be on prenatal diagnosis and successful intrauterine transfusion in severe fetal anemia and hydrops fetalis, secondary to parvovirus B19 infection.
Hello, my name is Nguyen Quang. I'm presenting on behalf of VMAC Time City Hospital and Penn University. This case discusses a common but often overlooked cause of fetal anemia and hydrocephalus, and from there show how physiology-driven decision-making can rapidly reverse a life-threatening fetal condition. No conflict of interest to declare patient consent was obtained for academic discussion. Parvovirus B19 is a common human virus and the cause of fifth disease. In non-immune pregnant individual, the vertical transmission can occur and may lead to severe fetal anemia and hydrops. The clinical point here is that early diagnosis and ultrasound surveillance are essential because intrauterine transfusion in specialized referral center markedly improve fetal survival compared with no transfusion. With the post-pandemic resurgence, we need to have a high index of suspicion when sonographic marker of fetal anemia. Our patient was a 21-year-old, gravida 2, para 1, with one prior uncomplicated term vaginal delivery. She had no chronic medical condition and no significant family history. She reported no rash illness and no known sick contact. The first trimester screening was reassuring. The neutral translucency measured 1 millimeters, and cell-free DNA was low risk for common trisomies. However, at a routine ultrasound at 20 weeks, new findings appear. Fetal edema with an enlarged heart, pericardial effusion, and enlarged liver, along with Doppler evidence of severe fetal anemia. Because of the combination of hydrops and anemia physiology, she was urgently referred to maternal fetal medicine. This slide shows the middle cerebral artery Doppler. The peak systolic velocity is approximately 2.2 multiples of the median, well above the 1.55 threshold, consistent with severe fetal anemia. This was the physiological marker that makes the situation time critical. On ultrasound, the fetus demonstrated cardiomegaly with pericardial effusion. This is one of the classic ways hydrops declare itself: fluid accumulation and cardiac strain in the setting of profound anemia. Furthermore, the image also shows free fluid in the fetal abdomen, consistent with ascites. Together with prior cardiac finding, this confirms established hydrocephalus rather than an isolated abnormality. At this stage, there were multiple potential causes of severe fetal anemia and hydrops that you can see here on the screen, including conditions such as hemoglobinopathy and red cell alloimmunization. Initial laboratory testing did not support alpha-thalassemia, as parental indices were not decreased, and screening for abnormal maternal antibodies was also negative. Maternal serology later demonstrated parvovirus B19 IgM positivity with equivalent IgG. Because severe fetal anemia can also associate with neurological injury, fetal brain MRI was obtained and showed no normality as well. To complete all of these diagnostic evaluation for all of these possibilities would have required significant time, during which the fetus was at high risk of rapid deterioration. Given the severity of anemia and established hydrophysiology, treatment was guided by physiologic urgency, with diagnostic testing pursued in parallel rather than delaying intervention. What was the treatment? So urgent fetal fluid sampling was performed, followed immediately by emergency intrauterine transfusion using concentrated red blood cell product with an 80% hematocrit, blood group O Rh negative. In parallel to this treatment, amniotic fluid was sent for parvovirus B19 PCR with a chromosomal and genomic evaluation. The fetal response to treatment was rapid. At 72 hours, follow-up ultrasound demonstrated improvement in Doppler parameters with partial resolution of hydrops. By day 7, effusion had completely resolved. With continuous serial ultrasound and middle cerebral artery Doppler surveillance, cardiac size and function normalized by 24 weeks. Final diagnosis was also confirmed through PCR, with chromosomal microarray and whole exome sequencing were negative. MRI showed normal fetal brain structure at 31 weeks, seen here in the picture, and at 37 weeks, the patient delivered 2,500 gram neonate vaginally, and the infant remained clinically well at 3 months of age. This case illustrates a low-cost strategy for managing severe fetal anemia, which double evidence of fetal compromise rather than delayed etiological confirmation trigger life-saving intervention. In the post-COVID era, parvovirus B19 has re-emerged as an important cause of non-immune hydrocephalus, likely contributing to increased fetal morbidity when recognition is delayed. The differential diagnosis in this setting remain broad, including red cell alloimmunization, fetal maternal hemorrhage, hemoglobinopathy such as alpha-thalassemia, congenital infection, and genetic and structural causes of hydrocephalus. With such a broad differential diagnosis, the transition principle here is a shift from pathogen center to physiology-driven intervention, where Doppler finding, not delayed confirmation, determines survival. Rapid access to fetal blood sampling with preparedness for intrauterine transfusion enables swift reversal of hydrops within days, preventing progression to cardiac failure or neurological injury, and transforming a high mortality condition into one with favorable neonate outcome. Because MCA Doppler assessment and intrauterine transfusion rely on widely available ultrasound and standard blood product, this approach is scalable across a diverse resource settings. So the take-home message here is simple. In early second semester, non-immune hydrocephalus, elevated NCA Doppler warrants an immediate evaluation for virus B19 and prompt access to intrauterine transfusion, allowing rapid reversal of hydrops and improved neonate outcome. Thank you.
Good day all.
Thank you for that interesting case on non-immune hydrops vitalis and outlining the differential and best management practices in limited resource settings. Thank you.
Good day all.
The next case report will be on a retained fetal bone following term C-section, unmasking a rare etiology of secondary infertility managed by hysteroscopy.
I'm Dr. Edima Olori. I'm presenting a case report on retained fetal bone following term cesarean delivery, unmasking a rare etiology of secondary infertility managed by hysteroscopy. My mentors are Dr. Edet and Dr. Akpanika. I have no conflict of interest to disclose. By means of introduction, retained intrauterine bone is a rare cause of infertility, affecting less than 1% of infertile women. It's usually associated with a past history of mid-trimester termination of pregnancy, but can also result from other causes. It causes infertility by acting like an intrauterine device, triggering inflammation, thereby preventing implantation. Hysteroscopy is both diagnostic and therapeutically beneficial in the management of this case. I present Mrs. Andy, a 31-year-old para 2+0 who presented with a 1-year history of inability to conceive, 3 months history of brownie discharge, and occasional postcoital bleeding. Her last menstrual period was 20th of November 2024. She has regular cycle, no pelvic issues, and her husband is a 40-year-old and has no sexual dysfunction. She has had 2 cesarean sections in 2014 and 2023 respectively. Second confinement in 2023 was booked late, and she delivered via an emergency cesarean section with no complication. Child died at 6 months of age. There was no history of miscarriage, abortion, contraceptive use, blood transfusion, or chronic medical illness. She presented with a pelvic ultrasound scan suggestive of a foreign body in the endometrial cavity. On examination, her general physical condition as well as her vital signs were stable. Abdomen revealed a previous surgical scar. There was no abdominal tenderness, organomegaly, and palpable mass. Vaginal examination showed normal vulva and vagina with offensive brownie discharge. A diagnosis of secondary infertility likely due to intrauterine pathology was made, with differentials including retained fetal bone with chronic PID, osseous metaplasia, intrauterine calcification, and endometrial tuberculosis. Baseline investigations done showed no abnormality. She was commenced on broad-spectrum antibiotics and switched to targeted antibiotics after culture results were out. She was booked for hysteroscopy and laparoscopy initially, but declined due to cost. After 2 failed attempts at removal elsewhere, she consented and had the procedure done in October 2025. Hysteroscopy revealed multiple bony fragments at the internal cervical os, extending into the endometrial cavity and with intrauterine adhesions. Hysteroscopic adhesiolysis was done after removal of retained fetal bone. Laparoscopy showed moderate pelvic adhesions and bilateral tubal blockage. Retrieved samples were sent for histology. This is the hysteroscopic video showing the fetal bone removal as well as the hysteroscopic adhesiolysis. This is the fetal bone seen in the endometrial cavity, multiple fetal bone, and an hysteroscopic grasper was introduced into the cervical os to remove the multiple fetal bones that were retained in the endometrial cavity. After complete removal of the fetal bone, the endometrial cavity was inspected and she had intrauterine adhesions, and hysteroscopic scissors was introduced into the endometrial cavity and she had hysteroscopic adhesiolysis. And this was done until the cavity was completely devoid of scar tissues. These were the fetal bones that were removed hysteroscopically. She was discharged same day on analgesics and antibiotics. Intrauterine catheter was inserted for 10 days and she was placed on estrogen and progesterone for 3 months to enhance endometrial regeneration. She is currently undergoing evaluation for in vitro fertilization. Histology report confirmed the fetal bones. Most cases of intrauterine fetal bone usually follow a mid-trimester miscarriage. In countries like Nigeria, where abortion is illegal, procedures like this are usually performed by unqualified individuals and results in complications such as incomplete termination. Interestingly, this index case occurred following a term-life cesarean delivery, which is an extremely rare occurrence, possibly from an undiagnosed twin gestation with an early fetal demise of one twin in a case of dichorionic amniotic twin gestation. Therefore, early antenatal booking and detailed ultrasonography are essential. Careful inspection of the uterine cavity during cesarean section is critical, and blind intrauterine procedures should be avoided. While hysteroscopy, which is an evidence-based approach, remains the gold standard for diagnosis and treatment of intrauterine pathologies. In conclusion, women presenting with difficulty conceiving due to uterine factor, retained intrauterine fetal bone should be considered as one of the causes. It is important to note that other than a mid-trimester miscarriage, it could occur following a term pregnancy and cesarean delivery. Hysteroscopy remains the gold standard for management of this condition, and fertility is generally improved if managed accordingly. These are my references. Thank you very much.
Thank you so much for that interesting case on secondary infertility and retained products, as well as the legal settings that make it so complex. So we appreciate it. The following case is on uterine didelphys with vaginal septum.
Hello, my name is Dr. Papa Kusiopari. I'm a medical doctor from Ghana. Today, I present to you a rare case report of uterine didelphys with vaginal septum that happened in the Tekwashim Memorial Hospital in Ghana. My mentor is Dr. Aisha Tu Misuna, who is an OBGYN specialist, and these are my co-authors. Disclosures: the author declares no conflict of interest related to the work. Just a brief introduction. Uterine didelphys simply means double uterus. This is a case where it's a congenital anomaly. This is a case where the paramysonephric duct fails to fuse completely. So if you could see in this picture on my left side, this is a uterus. So in uterine didelphys, there's a separation from the top all the way to the bottom with 2 different uterus and then 2 cervices and then 2 vaginal canals. So now back to the case. So it was a 27-year-old who was 34 weeks pregnant. She was pregnant 3 times, had no kids, and then had 2 previous pregnancy loss. So she presented with lower abdominal pain and leaking amniotic fluid of 8 hours duration. She had no significant medical, surgical, and social history. So her first pregnancy was an induced abortion at 8 weeks. Second pregnancy was a miscarriage at 3 months. With regards to her current pregnancy, she completed all her antenatal investigations, which were normal. Her routine medications were adhered to. She did about 3 to 4 obstetric scans, which were all remarkable. And this highlights limitations of routine imaging in detecting anomalies. Gynecological history and social history was unremarkable. Family history: she had twins on both maternal and paternal side. On assessment, she was 34 weeks pregnant. SFH was 33 cm, longitudinal line, cephalic presentation, descent 5 feet. She was contracting 2 in 10, lasting 25 to 28 seconds. She declined to speculum examination, so wasn't performed. Vital signs were recorded. uh, and then they were grossly fine. Fetal heart rate was 158 beats per minute. Initial impression was latent phase of preterm labor, and this was the plan. Contractions and fetal heart was carried out. Fetal heart monitoring was carried out 4 hourly. Client was noticed to be actively contracting 12 hours later with strong contractions, about 3 in 10 lasting 45 to 48 seconds. An initial vaginal examination was done at maternity ward, which showed that client was 8 cm dilated. Client was transferred out to labor ward. At labor ward, client was noticed to be 2 cm dilated rather. Doctor on duty was called, and then upon arrival, it was detected that client was having 2 vaginal canals. This is the right canal showing that showed the 2 cm dilatation, and you could actually palpate the fetal part. And this is the vaginal canal, the left one, which was actually empty and you couldn't feel any service. Just around that time, client was noticed to be in distress, so an emergency cesarean section was done. Unfortunately, we had a fresh stillbirth, and then this is a picture showing the intrapartum. This is the uterus, and this is the other uterus. This is the right uterus that contained the baby. So client was managed accordingly with the routine post-op management. We are still very in touch with this client. The plan is to monitor her until her next pregnancy, and then we schedule her for an elective cesarean section at 34 weeks. We had to do an HSG, which is on the left over here, and then an MRI to confirm the diagnosis. And this MRI could see the 2 cervices with the division over here, the 2 uterus with the division as well. The discussion points, the client was unaware of having this condition throughout her whole life. She had about 6 to 7 lifetime partners, but they never discovered this. Our routine scans and our routine examinations that were done at the antenatal clinic also failed us because she had adequate visits and adequate scans, but yet this case was not diagnosed. This case clearly underscores the critical gaps in our Ghana maternal healthcare system. We believe that enhanced antenatal screenings and then provider trainings to recognize unusual labor presentations would really help us not miss cases like this. And these are our references. Thank you.
Thank you for that case highlighting the way in which uterine and Müllerian anomalies can impact pregnancies and raising awareness of how identifying them early on can improve prenatal care. The next case is titled From OR Table to IR Table, Embolization of the Uterine Artery Pseudoaneurysm After Cesarean and Salpingectomy.
Hello and welcome. My name is Dr. Raisha Rashid. I will be presenting from OR table to IR table. Embolization of uterine artery pseudoaneurysms after cesarean section and salpingectomy. My mentor is Dr. Hina Patan and my team members are Dr. Fatma Kesser and Dr. Harvey Bilal. I have no conflicts of interest to disclose. This is a history of Gravida 6 para 35 years old female who underwent cesarean section and bilateral salpingectomy. On first postoperative day, the patient developed abdominal distension and tenderness. Her ultrasound was done and it showed hemoperitoneum. Patient was referred to Aga Khan Hospital. Her pulse was 120, her hemoglobin was 8.2, her WBC count and serum CRP level were raised. Next, the imaging was done and the ultrasound showed moderate hemoperitoneum. And a large hematoma was seen anterior to the uterine body with approximate volume of 93 ml. CT abdomen and pelvis with contrast was done and the axial section showed a saccular lesion that was enhancing on the arterial face similar to the adjacent vessels. It was representing right-sided pseudoaneurysm, while on the left side contrast was seen pooling and it represented active arterial bleed. The patient was then moved to the IR. Catheterization of left internal iliac artery was done and contrast was given. The first image is showing the left uterine artery. The second image is showing a smaller branch of left uterine artery that is feeding a large pseudoaneurysm seen in the third image. Selective catheterization of left uterine artery was done, followed by embolization. Then catheterization of right internal iliac artery was done, which is showing right uterine artery in the first image. The second image shows a pseudoaneurysm. Then selective catheterization of right uterine artery was done, followed by embolization. Now we are looking at the course of events. After having the cesarean section, the patient was referred to Aga Khan Hospital as she developed hemoperitoneum. At Aga Khan, bilateral uterine pseudoaneurysm were diagnosed and embolized. The patient was shifted to the ward where 4-pack cell volume were transfused and a peritoneal pigtail catheter was placed and antibiotics were given. After 2 days, the peritoneal drain was removed because the output was minimal and HB was 11.4. Few days later, the patient was discharged in stable condition. After 6 months, the patient got imaging done and there was complete resolution of hemoperitoneum and hematoma. Now the discussion, uterine artery pseudoaneurysm is a rare cause of secondary PPH. The prevalence is 2 to 3 per 1,000 patients and the results from arterial wall injury. The risk factors are pelvic trauma, infection, neoplasm, and surgery. Differential diagnoses include arteriovenous fistula, arteriovenous malformation, and vessel rupture. The management is uterine artery embolization, minimally invasive and uterine sparing treatment, and it is safe and effective. Common embolic agents that can be used are polyvinyl alcohol particles, trisacral gelatin microspheres, and N-butyl cyanoacrylate. Now with the take-home message, uterine artery pseudoaneurysm, though rare, should be suspected in delayed postpartum hemorrhage. Prompt diagnosis with imaging is recommended, and timely uterine artery embolization can be life-saving and uterus-sparing in hemodynamically stable patients. Thank you very much for listening, and these are my references.
Thank you so much for sharing. As we all know, postpartum hemorrhage has taken the lives of so many women, and being proactive and knowing how to manage this, including minimally invasive procedures, is important. The next case is on an extremely rare twist in acute pelvic pain, tale of a dying leiomyoma.
Hi, I am Dr. Ahmed Raza. I am working as a Year 3 resident at the Department of Radiology, Aga Khan University Hospital, Pakistan. I will be presenting a case which is titled An Extremely Rare Twist in Acute Pelvic Pain, Tale of a Dying Leiomyoma. My mentor is Dr. Gulnaz Shafkat, who is a women's imaging faculty, and my team members are Dr. Khabar Bilal and Dr. Muzammil Shakil. I have no disclosures. So this is a case of a 32 years old female who presented with history of sudden onset severe lower abdominal pain, which she described as sharp, colicky, and radiating to her lower back. She also had nausea and low-grade fever. She was nulliparous and had no prior medical comorbidities or gynecological disorders. She had never underwent prior gynecological imaging. She described herself as a homemaker and belonged to a lower middle class family. Her examination revealed mild pallor, and palpation of her abdomen revealed mild tenderness and a firm mass in the lower abdomen. Her investigations revealed mild anemia as she had an HB of 9.2, and she also had an elevated LDH levels of 422, which was suggestive of tissue ischemia and cell death. 1 week earlier, patient's pain started intermittently, which patient described as mild cramping, and at that time she underwent ultrasound examination of pelvis parabdominally, which revealed intramural uterine fibroid and associated diffuse adenomyosis. These findings can be appreciated on these ultrasonographic images, in which the image on right side of the screen is demonstrating a well-circumscribed hypoechoic focus as being pointed out by arrowheads. This was concluded as fibroid, and the image on left side of the screen is demonstrating heterogeneous bulky myometrium without distinct visualization of adjacent endometrium in the anterior uterine wall as encircled by these dashed lines. This was concluded as adenomyosis. Patient was being managed conservatively with analgesics when she got a discharge on request on the same day without any further workup, citing some socioeconomic and logistic constraints. Advanced imaging, that is MRI, was pursued 1 week later on her current presentation when patient had worsening pain, which prompted her revisit to the hospital. These are MRI pelvis images of the patient, in which there is partial visualization of uterus on this axial section. We can also appreciate visualization of a large circumscribing the anterior wall of the uterus, representing subserosal leiomyoma. The above image is demonstrating a T2 hypointense area near the attachment base of this subserosal leiomyoma, representing its vascular pedicle. It is giving somewhat whorled appearance, which is suspicious for torsion of this subserosal leiomyoma. However, this diagnosis requires hallmark imaging features, which we will be going through on the next slide. This slide is also demonstrating T2 hyperintense focus within the myometrium, representing internal necrosis and degeneration, as well as internal T1 hyperintense focus within the leiomyoma, representing internal hemorrhage. T1 post-contrast sequence in of a thin rim of hyperenhancement along the periphery
We notice that the video stopped, so we're correcting that right now.
Within the myometrium, representing internal necrosis and degeneration, as well as internal T1 hyperintense focus within the leiomyoma, representing internal hemorrhage. T1 post-contrast sequence in sagittal projection on this slide is demonstrating few features highly suggestive of torsion of leiomyoma. First of all, we can appreciate visualization of a normally enhancing uterus over here. We can also appreciate visualization of a large fibroid arising from the anterior wall of the uterus. Complete non-enhancement of this fibroid is suggesting its complete devascularization. There is also appreciation of a thin rim of hyperenhancement along the periphery of this large fibroid, which is representing vascular congestion in the periphery secondary to torsion of this fibroid. And lastly, there is demonstration of a fan-shaped area of complete non-enhancement in the uterus, just adjacent to the site of attachment of this leiomyoma to the uterus. This is known as dark fan sign, and it is seen in cases of torsion of subserosal leiomyoma. After relieving her pain in ER and in the light of MR imaging findings, patient was immediately taken to the operating room, where she had an open uterine myomectomy with complete resection. Intraoperatively, There was a 720 degrees twist of the vascular pedicle of the leiomyoma. Rest of the uterus and bilateral ovaries appeared normal and therefore they were preserved. Patient was discharged in a stable condition and she is not having any gynecological complaints currently. Later on, histopathological examination of the resected leiomyoma demonstrated hemorrhage, extensive degeneration, and necrosis, which were correlating with the prior imaging findings. Now coming to the discussion and take-home messages from our case, women of Southeast Asian descent have a 29% higher rate of fibroid diagnosis. Torsion of a pedunculated subserosal leiomyoma is an extremely rare diagnosis with an incidence rate of less than 0.25%. However, it should be considered in the differential diagnosis of acute pelvic pain, especially in females with known history of fibroids. There always remains a risk of misdiagnosis of leiomyoma torsion as some other myometrial pathology, especially on ultrasound examination, as we experienced in our case. In such equivocal cases, MRI is very helpful with its hallmark features, especially the
Thank you for that presentation on acute pelvic pain and leiomyomas and torsions as well. It's something that's rare but very important to recognize as it is a surgical emergency. So appreciate that presentation. And now to present our final case, pheochromocytoma in pregnancy.
Good day. My name is Dr. Elijah Thagana Kagondo from the Department of Obstetrics and Gynecology at Kenyatta National Hospital. I present a rare and high-risk case titled pheochromocytoma in pregnancy, managed through a multidisciplinary approach in a resource-limited setting under the mentorship of Dr. Rosa Chimwei. I declare no conflicts of interest. However, due to the patient's financial limitations, the clinical team at the hospital mobilized support to facilitate essential investigations and medications, including the plasma and urinary metanephrines and the procurement of phenoxybenzamine, reflecting real-world challenges in low-income settings such as ours. In the history of the patient, this was a 35-year-old para 1 plus 0 gravida 2 who presented at 15 weeks and 6 days gestation with non-chronic hypertension, poorly compliant to treatment and not on any specialized clinic follow-up. She presented with recurrent postprandial vomiting, headache, and generalized abdominal pain over 3 days. On examination, she was dehydrated, hypotensive at 99/52, and tachycardic at 134 beats per minute with epigastric tenderness and a palpable pelvic mass. Socially, she had no health insurance, came from a low socioeconomic status, and had limited access to healthcare. On the second day of admission, she developed generalized tonic-clonic seizures, which were accompanied by markedly labile blood pressures, prompting evaluation for secondary causes of hypertension. So in our investigations, our hemogram came back normal, our UCs came back normal. In the LFTs, we saw a slight increase in our gamma GT, and the serum cortisol was 653.7 with elevated plasma and urinary metanephrines as displayed. In the imaging, we found a normal head CT scan, normal EEG, and the abdominopelvic MRI showed bilateral large para-aortic masses, the pheochromocytomas as labeled in the diagram, in the scan uploaded. So, course of disease, we saw that this patient had challenges in the blood pressure control, and we had to optimize by adding methyl dopa to the ongoing nifedipine. We also had a multidisciplinary discussion, and we made the target to excise the tumors at 25 weeks and 4 days with an intrauterine fetus. However, we needed to do prior alpha blockade for 14 days with phenoxybenzamine, which we managed to achieve. Blood pressure elevation during the manipulation of the masses was achieved by administering labetalol and magnesium sulfate intraoperatively. And a total right adrenalectomy and a partial left adrenalectomy was done in conjunction with the excision of the tumors. Post-operative obstetric ultrasound showed normal fetal parameters, and we added hydrocortisone to counter adrenal insufficiency, and the patient was monitored in the HDU. Postoperative complications included the labile BPs, steroid-induced diabetes mellitus, valvular candidiasis, and adrenal insufficiency. There are the excised tumors, and histopathologically, we also confirmed that there were pheochromocytomas. At 34 weeks, we noted fetal growth restriction, and this necessitated an emergency cesarean section. We delivered a male neonate weighing 1,840 grams with good APGAR scores 8 in 1, 9 in 5, and 10 in 10 minutes. And the neonate was nursed in the NBU for the first 24 hours and was discharged along with the mother 1 week later, stable, and the mother is now currently on follow-up in the endocrinology clinic at Kenyatta National Hospital and with good blood pressure values. So in our discussion now, pheochromocytoma in pregnancy is exceedingly rare, yet it carries high maternal and fetal risk if left unrecognized. This case underscores the importance of investigating atypical or labile hypertension in pregnancy, early multidisciplinary involvement, and strengthening patient education and referral system, particularly in resource-limited settings. With timely recognition and coordinated care, we hope for favorable outcomes, and they are achievable. And we hope that this case can contribute to further research and improvement in diagnosis, recognition, and management of pheochromocytoma in pregnancy, especially in a low-resource setting such as ours. These are my above references. Thank you very much.
Thank you. So a reminder to keep your differential broad when you encounter hypertension in pregnancy, which is very commonly seen. So thank you for that presentation. And so that brings us to, hold on one second. So that brings us to the end of today's case presentations. We have had an extraordinary range of cases spanning from obstetrics, gynecology, gynecologic oncology, from complex conditions in pregnancy and rare surgical emergencies to reproductive and oncological challenges managed in diverse resource settings, all reflecting our shared commitment to caring for women around the world. We want to sincerely thank all the presenters for sharing their thoughtful, clinically rigorous, and globally relevant work. The preparation, insight, and care reflected in these cases truly made this a rewarding experience for the judges. At this time, our judges will step away to thoughtfully deliberate. While they do so, we invite everyone to participate in the People's Choice Award by submitting their votes. We also will be mindful of time because as we can recognize our colleagues in Vietnam it's quite late over there. And we deeply appreciate your participation. Thank you all for your patience and for being part of this meaningful experience.
So
All right. Just wanted to say a final thanks to everyone who participated. Every case was very, very interesting and really appreciated your time. And congratulations to all the winners.
Yes, thank you so much for spending your evenings with us. And we really appreciated learning all the different things that you guys had and the cases that you guys presented. And really just excellent job to everyone who did present. After this, we will send a certificate of participation and instructions regarding how to receive the payments. Just to put that out there, it can take a bit of time and with the minimum of a month because it's a bit of a complex process, but we will send you that information from the Penn email that you received the previous information from. All right. And so for us to just move forward and so that people can move on with their evenings, we are going to present the awards. All right. Starting with first, the People's Choice Award goes to Dr. Raza on his presentation on an extremely rare twist in pelvic pain, tale of a dying lyoma. So congratulations on this. It seemed like the audience favorite. We thought, and collectively we found that case very interesting. And then next will be our third place, which will also be the cash prize of $250 USD, goes to Dr. Akiani, who presented on sigmoid volvus around a pedunculated fibroid in mid-pregnancy, a rare case of acute abdomen with an unusual diagnostic challenge in low resource settings. This was a great presentation on how to the differential for acute abdomen and proceeding with management, emergent management in order to address the emergency, but as well as also managing, to address the emergency as well as managing the pregnancy appropriately. So congratulations. The second place goes to Dr. Nguyen, who presented on the contralateral paradox, a rare cross ovira variant with pyosalpinx on the non-obstructed side. We really appreciated the images that you presented and such a rare case. So congratulations to you with the cash prize of 500 USD. And then lastly, for first place goes to the first place goes to Dr. Olori, which is a retained fetal bones following term C-section delivery, masking a rare etiology of secondary infertility managed by hysteroscopy. We really appreciated the visuals and the images provided, and as well as just remembering that, this is one of those complications that we can see when there are barriers to reproductive access. So thank you so much for presenting on that. We really appreciated you guys spending your time with us, and we would love to hear any feedback that you guys have going forward.
All right. Thank you, everyone.
Bye. Have a great evening.